Okay, well, thank you for staying. We're going to go ahead and get started with our afternoon panel. This afternoon's panel will provide insight into the health IT staffing challenges, gaps, and best practices from a variety of healthcare systems. Their different sizes, their delivery, population served are all very unique and different. But we want to thank our panelists for coming here to be with us today. Some have traveled. Go ahead and go over some of their bios for you. Okay, Todd Tangeman is Vice President of Human Resources Director at Newton Medical Center. Todd is a solution-oriented human resources and business leader with more than 20 years of experience in multiple industries, including manufacturing, technology, consulting, and 12 years in healthcare. He currently serves Newton Medical Center as Vice President of Human Resources and Corporate Compliance Officer. Prior to joining Newton Medical Center in 2006, Todd served as the human resources leadership roles with Providence Health System in Oregon, Washington, Alaska, California, that included support of their organization's 400-employee IT division. Todd and his family live in the country east of Newton. He is active with the Newton Area Chamber of Commerce, Hutchinson Community College, Advisory Board, Health Harvey Coalition, and currently serves as an officer with the Kansas Hospital Human Resource Association. He has an undergraduate degree in mass communication and economics and a graduate degree in business and leadership. Bob Davidson is Chief Information Officer at Hutchinson Clinic. Bob has been the Chief Information Officer for the Hutchinson Clinic since 2006. The clinic is a multi-specialty ambulatory care clinic center with approximately 90 providers at 6 locations and 20 outreach clinics, providing medical services for 250,000 patients in Kansas. Bob is a member of several national committee and special interest groups related to the development of health information systems, including the Allscripts EHR Executive Forum, Allscripts Practice Management Advisory Council, and the Group Practice Improvement Network, Allscripts Optimization Group. Since his hiring at the Hutchinson Clinic, went from paper charts to being one of the Allscripts premier development partners and early adopters of new technology systems, and was one of the initial Kansas Health Information Network participants to go live on KHAN and receive national recognition as one of the first in the nation to transmit personal health information using XDS.B formatted clinical summaries. Doris Rogers, Vice President, Human Resources at St. Luke's Hospital. Doris is the Vice President of Human Resources at St. Luke's Hospital of Kansas City, where she has been in HR for the past 17 years. She received her undergraduate degree from the University of Minnesota in child psychology following graduation. Doris began working at Washburn Child Guidance Center, a day treatment facility for children with behavioral disorders in Minneapolis. While a very rewarding profession, Doris realized she wanted to pursue a different path and began a career at St. Luke's while completing her master's degree in human resources management at Webster University. In her current role, she is the administrator over the Human Resources Department, the hospital's Child Care Center, and the Volunteer Services Department. She is a member of the hospital's executive team, a member of the health system's Diversity Council, and Diversity Trainer. Doris is involved in her community by currently serving on the board of directors for KC Care Clinic, Mill Creek Parks Association. She is an active member in the church and enjoys traveling with her family. We have a fourth panelist that is most likely on his way, so he's just not here yet. Ralph Caro, who's the Chief Operations Officer at Samuel U. Rodgers Health Center. I'll go ahead and read his bio. Hopefully he can just walk in and join us. A native of Kansas City, Kansas, Ralph Caro Jr. obtained his undergraduate degree from the University of Kansas and completed his master's at the University of Missouri, Kansas City. Caro is a certified management practice executive, Medical Group Management Association, also a certified administrator in physician practice management, and the American Academy of Medical Management and Executive Fellow in Practice Management, American Academy of Medical Management. He's currently the Chief Operating Officer at Samuel U. Rodgers Health Center in Kansas City, Missouri, where he has been since 2008. Caro is responsible for the day-to-day operations of a multi-site healthcare system. He is charged with the development and implementation of strategic initiatives. Additionally, he ensures the achievement of the health system's mission, vision, and goals through effective use of human, financial, material, and intellectual resources. I neglected to introduce myself, kind of like Paul, I guess, earlier. I'm Linda Gerber. I'm with American Consultants, and we are a staffing and consulting company. We do clinical and health information technology. So that's my background. So I guess we're ready to get started. Thank you, panelists. I will let each one of you just give a little overview, additional information if you'd like.
I hope everybody can hear me here. I'm Bob Davidson. I'm Chief Information Officer at the Hutchinson Clinic, about 200 miles southwest of here. Dr. Waldren, in a couple of his slides, really touched home with the situation for the Hutchinson Clinic. We are the largest town between Hutchinson and Denver, and we serve a very large area of the state, about 10,000 square miles. That area is getting older, they're getting poorer, and their doctors are leaving. And so we have a responsibility, we feel we have a responsibility to reach out to those areas. And so connecting to those hospitals with technology, connecting to other physicians out there, supporting their health information really helps us because we hold all the specialists. For instance, Dodge City, which is about 2 hours away, has no neurology specialists. We do. Those patients, stroke victims, whatever, have to come to make that 2-hour drive to Hutchinson to connect. Hopefully, we can connect with their primary care doctors and to reach out and share what we have in our system with what they have. That's been our goal all along with the Hutchinson Clinic. We as you could tell from the bio, we have 250,000 active patients. We live in a city of 40,000, so that's kind of the scope that we're dealing with. As in the bio, it was described that we are one of the premier customers for Allscripts, which is about third or fourth largest in the country as far as the installations of EHR systems. And I get to sit with those folks and learn what's coming down the pipe, and there's plenty coming down the pipe, has been discussed today. And I'm very excited about the future. We've gone a long ways in just the last few years, and I'm really anticipating tackling some of those problems that we come across.
I'm Doris Rogers, and I'm the Vice President of Human Resources at St. Luke's Hospital, and I've been there for 17 years in HR. St. Luke's is a large health system, privately and locally owned, and we have 10 hospitals across 6 of them are in the metro and then some in rural areas, as well as we do behavioral health, an employee assistance program. We have about 50 physician practices and serve a 67 county area, so a pretty broad span. For us right now, one of the things that is exciting from an IT perspective is we are implementing, we just signed with Epic, and so they are coming into our organization. We're in phase 1 as of October, where our staff is just now getting trained, having to test so that they can be in that environment. And I think what was neat, something that we did and that our employees appreciated, was to get the buy-in. They chose it. We had our physicians and our nurses participate in the demos, and they're the ones that decided what we would have and what we would use, so there wasn't the later administration or executives. They're the ones that chose this, and that's why I can't do it. So I think that's been good for us as far as starting. Let's see, I think that's all I have to say about St. Luke's for now.
I'm Todd Tangeman with Newton Medical Center, and just a little more information about who we are. We're a single hospital supporting our community of Newton and the surrounding area. 100-bed, 600 employees. We have several clinics in surrounding communities. And in terms of patients, about 25 per year, 2,500 inpatient stays, 54,000 outpatient procedures, 13,000 ED visits per year, and about 19,000 clinic visits. The system that we use for electronic health records is Meditech, and we do have our IT and our data center is on site. So just a little bit about where we're at.
Okay, thank you. All right, well, we're going to go ahead and get started with some questions, and I'll start off here, and then you, the audience, will have an opportunity, just like the morning's format, to ask some questions as well. So the first one, and whoever wants to start first, that's up to you guys. How has healthcare changes impacted your IT data management workforce the last 5 years, including number of employees?
Go ahead.
Okay. When we implemented our electronic medical record system, we went live on January 28th, 2008, and so we just passed our 5th anniversary. Prior to that, you may have heard me blurt a while ago that I had a manufacturing background. I was hired about 1.5 years before we went live with our electronic medical record system. And truly, the Hutchinson clinic was not very techno. We didn't even have an IT department. I had to put together an IT department from scratch. What they called information systems was really help desk for the practice management system that we had, and not a single one of them could hook up a printer to a PC or whatever that might need. So we had to start from there. Again, that was back in 2006 when I started. And probably about $24 million later, here I am, and I've got 7 IT people, and I have 4 electronic health records support specialists, and I have 1 practice management billing system support specialist. We try to handle as much of the desktop support for those applications that we possibly can. The things that have changed drastically for us is, again, all we had before was a practice management system, a billing and scheduling system. And now we have about 23 different enterprise-type applications running, the radiology information system, lab information system, on and on. And we've integrated most of those. Some of them we don't find essential to interface with our either our practice management or EHR hub systems. But it's a very complex situation. I've had to change staff members a couple of times in our highly technical jobs, the highly technical IT people like the server administrator, network administrator, just because we had gone past the knowledge and capabilities of the people that were in those positions before. And I started off with 1 EHR support specialist. Again, we have about 90 providers, 700 employees, a couple of hundred in the nursing roles, and we had all these people to train. We were not progressing very rapidly in our adoption, and so we increased the staff to 2, and the EHR support staff to 2 people. And then as I became more involved with other organizations, other user groups and things like that, I started asking around about how well they were staffed, and I actually put together structured surveys to find out what level of adoption that they had gone to, and how many people that they had, how many providers, how many locations, all that kind of stuff. And so I was able to use that a little muscle to actually add more staff people to increase our adoption and move forward. Today, we're sitting in a very good place. We still have a long ways to go just based on all the things that are coming our way. But I feel like we're adequately staffed and probably on the upper end of those surveys that I was talking about, the ratios providers to specialists, support specialists.
Okay, I'd like to take a break real quick and just introduce Ralph Caro. Sorry, we started a little bit early, Ralph, so
okay.
I already did your intro and your bio. So if you want to just quickly give a little bit of detail on CMIO Rodgers and what you guys do there real quick.
Sure.
And then I'll repeat the question.
Okay. Samuel Rodgers is a federally qualified health center. We were the first community health center in the state of Missouri and number 4 nationally. Our roots go back to 1967 when they started with about 15 staff and 1 doctor. Today, we have 8 locations. We're a multi-specialty practice. We have about 212 employees, 27 of which are medical providers. We offer women's health, adult and senior services, pediatrics. I do have an all-digital imaging department along with dental, behavioral health, and pharmacy and lab, all under one roof, and a WIC department. When I first came over to Sam Rodgers in 2008, we had about 300 nodes on our network, and we had 2 IT professionals. Taking a look at the affordable health care and the changes that the government, HRSA in particular, was promoting for community health centers, I knew that we needed a real tight infrastructure. And I also realized very quickly when I asked one of my IT professionals, tell me everything you know about cloud technology. And they're saying, well, it doesn't look like it's going to rain. I knew we were in trouble. Since that time, we have outsourced our entire IT department. I have a network administrator and I have a systems administrator. We now have about 600 nodes on the network. We just recently moved into a brand new facility, so we took advantage of all the marvels of technology. Everything in the building is wireless. We get pretty good reception. We use wireless technology with our electronic health record. All exam rooms are equipped. All the operatories are equipped. We're a very culturally diverse organization. We have 32 different languages and cultures. So we utilize a lot of interpreters. And so we have Microsoft Link for our interpreters to stay in touch with our providers. So you can summon an interpreter, language-based interpreter, by sending them a text message, and they will respond back to you via text. We're experimenting today with teleradiology. We're getting ready to go live next Monday with Truman Medical Centers and Children's Mercy Hospital, wherein we will transmit all of our x-rays, mammograms, and ultrasounds electronically. Experimenting also today with tele-interpreting services. I can't hire enough interpreters to keep up with the demand. So presently we have an experiment underway where the patient shows up, the nurse assistant will take a look, what is the desired language that the patient would like to communicate in. One click, we're online. We have columns, blue for male, pink for female. You pick the language, and then instantaneously you have an interpreter. In the past, the technology was to use a 2-handed handset, a phone handset, and patients don't like it because who am I giving all this information to? Doctors don't like it because now they're repeating everything twice. So we're optimistic that the video where the patient can actually see the interpreter will be a means to satisfy those patient requirements when language and culture are barriers.
Awesome, thank you. Doris or Todd, kind of back to the first question, how have healthcare changes impacted your IT data management workforce the last 5 years, including numbers of employees?
For us at St. Luke's, I think one of the ways that it's changed our workforce's size. As I said, we have a large health system. We have about 10,000 employees, and with them being spread in clinics and hospitals, trying to provide the best services to patients and being able to integrate everything that we're doing. With us as far as changes, we've had our structural changes. We have a chief information officer, and then there are various divisions. I joked with Deb when we were talking about coming here, and I said, I work in HR. IT is like a conglomerate at St. Luke's Health System because of all the different professionals we have there. The changes in them having to look at processes and how we deliver care, outcomes, and so forth, I think it's been a challenge in just trying to figure out our structure and what we would do to respond to that. One of the things with us being so spread out is we have telemedicine, and we've been doing e-health. We're one of the, I think, the leaders as far as using that. And it's wonderful for a physician who's in one of our rural hospitals to be able to link into, we have various product lines, heart, neuro, cancer, and women's and children's services. And for a physician who is at Anderson County in Garnett to be able to link into the plaza to one of our neurologists for help, in the middle of the night has been wonderful. And we continue to expand what we can do with telemedicine in that way and with the e-health. Other ways that it has changed is for our current staff. We have long tenured staff at St. Luke's, and it's not anything to have worked there 25 years. We have people there that worked 40 years in St. Luke's. And for them, I think having to, you've been doing this one way for so long, and now you're going to have to do Epic. You're going to have to test in order to be able to stay here and have your job. And so learning a new platform, learning a new system, I think that has brought some changes as well. As far as, everything else with our workforce, I think nursing has experienced quite a few changes as it relates to it. I spoke with someone, and she said it's difficult because we used to have patients in the hospital longer, and now we're sending them home right away. And the scary thing is that we're sending them home and how to take care of them. She's talked about is the professionals work to stay with those patients. What's this developed so that we're able to family members so that they don't, because if they return, that we think work changes.
I would echo well. So for electronic health record into implementing a enterprise-wide system and working on that. So for the providers, systems has challenged us in the skills. Some people who have said, I'm not up for one round of change, and more. So we did lose a few people. I'm not into this to learn. Fortunate, but for the most part, meaning build our IT to and do that on super users that are out into each the IT for knowledge holders, the users out and about, able to address that.
As if you will, first leg of that stool is a moment ago I indicated. But the other three are all equally important. I have support staff, a mom with 2 kids with education, technology coming so quick, and so the employees just handle it. For computer classes, Word, Excel, overwhelms existing employees. Who are the providers? As mentioned, many into retirement, hoping the Factronic in 2014 will not get paid. Mandatory, initially was a Ralphism in the EHR. Well, no, CMS has required that. I had a with our chief health officer discussion was tablets. Do you see the tablet technology 10 years before it hits us? Doctors don't want right now to start with. Generations, he said the kids are looking, those are the tablets. So room to work group of kids and demands the technology. Last leg of the stool was and that is of our quality outcomes. Home and NQC, these buzzwords, we have to measure the quality of our outcomes. It's got to extract the data. The system will generate or finding understanding that can bridge with an IT and data out of the system and give us direction, enhance our outcomes.
Okay, thank you. That's a chance to ask a question before I ask the next one.
Okay, on. There we go.
Yeah. Good afternoon to a managed services. My thoughts on that? Why or why not?
Our van not really offered a hosted service, and we fight well with the staff that we find really good IT. Hutchinson, they've got certain larger towns. They go to Wichita to find a few that they're available. Honestly, I haven't services other than just technical things. Fortunately, things have worked in the fashion.
I'm a believer in our pharmacy company and lab. However, even though I outsource the sales, it's available for meaningful use at costs and it's reflected in the us. We have stability in the system, considering now majority of the hurdles piece back in. But again, that market and the demands are changing. My ability to find good at a rate that I can afford.
Echo what has been said. Part of it is a bit of a with our world, with our people. So there may be some promise of some with that, trying if that we could manage that effectively or efficiently in-house.
And Luke's, I think with our model, it does. We have a bit of very good working in our IT department. I think it's for us.
I might add, I mentioned that it has a lot of little clinics offering managed services.
So when you are for your organization, things you're bringing to the table to talent.
I'll start. I would say that we really need to use recruiting practices regarding the talent may just as there are roles there are. So we cast our net broadly. An internet post, and usually that will generate. And then if we find that that doesn't, next level tactics, and we begin doing some help for we made in trade or publications. Health is also for us, our folks who would be deemed, and then also to maybe user groups. It used for any or and of course then the more energy that we put into that.
Ours is the same process that we go through, putting it on most people from our web, people from word of mouth. Best resource, I heard a lot about clinical staff professionals, and as unit secretary, outstanding nurses, best talent because we know how they learn, ability to train others, helps to their as candidates that we look for our IT professionals, and this is another thing here. We're looking for having the tech with IT. That's but I think one of the things I think mentioned it previously, the soft skills, credibility to look for those individuals, project mid from beginning to end skills. They need to be an executive to get that physician buy-in skills are impaired. One of those things, how many people stations? Important because as you're trying that you need to be able to end with crucial conversation. You need to know how, because this is going to help you convince them that this is the way to go. So much broader range of recruiting people rather than do the technical.
Groups that we're talking agree with Doris. IT is IT and find those skills looking inside. As far as our health, everyone on staff right now from inside. The advantages that I found is that we're very productive. One of the reasons why we're development partners is everybody comes to us to find out a primary care that is seeing 45 patients a day. our goal when we started was that we wouldn't interfere with their productivity. Not only is it a break in the revenue stream, but it's also, there's a demand for our doctors. I mean, very high demand. We are the only show in town practically in Hutchinson. And so we had to deal with people that were familiar with their workflow. And that was very, very helpful to us. When it comes to the IT people, like I said, we advertise much the same as everybody else does. We haven't had a whole lot of luck when we put out ads for an EHR support specialist. There just isn't enough activity going on in our area of the state that has experienced people. I'm really grateful for the two community colleges in the state, Hutchinson and Johnson County, for starting up their programs. That's a very helpful thing, and I know that most of us here would be very glad to work with those organizations to help develop those programs, because the education community really needs to recognize where the demand is and where the need is. Sometimes some organizations, community college is much closer to the need, but a lot of the other larger universities, Wichita State, Kansas State, KU, they just keep cranking out people in the same degree, and they don't really pay attention to the job market that's out there. And I think it's really great that the community colleges are paying attention to that. And as I look through the high-tech pamphlet here, I see that they're really focusing a lot on where the need is. Workflow is very, very important. That's why we tend to look inside.
We utilize the same recruiting outlets that you've heard mentioned here. I think our challenges are a little unique just because of the nature of the size of our organization. Last week, my big headache was, where do I find someone that can interact with our quality department, with IT, and extracting the data out of the system? And I think I'm probably looking for a clinical informatics person that has a nursing degree, probably would solve that particular aspect. My latest worry is IDC 10. If I take you back about 4 years, our medical records staff, they evolved into health information management. And the next big frontier, in my opinion, is going to be as impactful as Y2K originally was, and that's this monster of coding with ICD-10. And if I take a look at the 6 people that I have in medical records or health information management today, I'm not certain they have the wherewithal that I can upgrade them into coders to understand. The impact of IC10 is that today there are about 11,000 medical codes. In October, there are going to be 71,000. So the impact is twofold. One, the doctors are going to be scared to death and they're going to be confused. And if I don't have at least 2 people that are experts that can hold their hands and walk them through that, I see a big frustration with doctors, the same frustration when we introduced the electronic health record. But the really, really big impact, if they code incorrectly, we aren't going to get paid. And if we don't get paid, we're out of business. So that's my new worry, is how do I assure a smooth transition from IDC 9 to IDC 10, and I only have about 6 months or less to find, train, recruit, train someone and get them on board.
Okay.
Can I just add a couple of other things that we look for? Is you're hearing, we're talking about what we need to do and what our organizations are doing. our strategic plans. Something else that an IT professional, when we're looking at, is if they understand governance. And just being able to look at an organization's strategic plan and be able to tell that executive, this is how this IT solution is going to help you get there. Being able to speak that language with them. And then another thing is Lean and Six Sigma principles. We're talking about all of the changes we need to make and the efficiencies we need to gain. We need someone who's able to facilitate that. Again, taking people through, here's what I can do for you on the IT side. I can tell you as an HR professional, I speak a different language than IT professionals because IT is very technical, and I'm the person that I don't want to call you for help because I feel stupid. And inevitably, when the IT person comes to my office and I call him, every time I call him, when he gets there, whatever it was that was wrong is fixed. And then I'm sitting there looking like, I promise you, Kurt, it really was broken. So it is to be able to speak the same language and know, and be able to talk to me in my language, which is much simpler, and let me know that you're going to be able to get me where I need to be and where this hospital needs to go.
So one quick takeaway would be, don't wait so long to ask for help, because the sooner you ask, the sooner it will fix itself. There you go. If you get nothing else from this conference, you learn one thing right there.
Very important.
Okay, we have a question over there. Hold on, he's going to bring the microphone.
Hi, thank you. From what I'm hearing, then there's, on the panel, there's a gap as well as a demand. So what I'm wondering in the future is, and from what I've researched, I would imagine there's a demand for people to be certified, whether it's coding or in IT or whatever. That's going to be the need for the future needs of the hospitals and clinics. So then anyone who doesn't have that certification is really not going to be able to fit the needs of where the gap is now and what the future projections are.
I think the certification piece is very important, but also the ability to learn. For us, when I was talking with our chief information officer, she was saying, I can send someone to get a certification, so that can come later. It's great if they already have it, but I can send them to do that. It's those other pieces that I'm looking for that are more difficult to train. I can train them to do IT. Sometimes I can't train them on all those broader skills, but the certification is definitely very helpful.
I might add to that, yes, like I said, I have hired all of my support specialists in-house, but if I didn't have anybody that was interested in that, and I had, in my particular situation, it's such a new technology that certification, knowing you know what you're talking about, is certainly helpful. Now, I know that you're missing the part where you have the experience and things like that, but the certification is you've applied yourself, and you've put the effort into doing the research, trying to making the career choice, and placing yourself in that work force. And myself, I believe that this is a job demand that's going to last for a long time. We aren't through with the changes. These changes, Ralph pointed out, ICD-10, there's ACOs, there's patient-centered medical home, there's connecting to everything under the sun, keeping it secure and safe, and making sure that the clinical staff understands what they're supposed to do and why, and coercing them into spending all that extra time into doing it and things like that. The certification in every situation is like having MD behind your name. I'm not going to have a whole lot of faith in you being able to clear my cholesterol problems if you don't have that behind you, and the same goes with the certification for health information technology.
Okay, kind of to jump off of that, do you guys currently have an organization plan where IT and HR is working together to identify the needs that you have upcoming and to help you with, how many staff you're going to have to add this year, and then helping you, how is the organization working together to find the right staff between HR and IT?
We do have that plan. We have a kind of a master plan, or more simply a to-do list on our IT side of the projects and the work that needs to be accomplished this year to meet our strategic objectives. And so we work off of that, and from there we can identify, well, what are the skills and the talent needs and the bandwidth in terms of people to accomplish all of that. And so we do work closely with our IT folks to come up with an understanding of what that looks like and kind of a plan going forward for this year, and recognizing that, okay, this year it's going to be items A, B, and C, then next year it'll be the next 3 or 4. And sometimes those the skill mix will vary. And so, we are looking at, we may just need one particular skill set for a short time. And so maybe the solution there is a temporary or short-term skill set. And so we're trying to keep that in the mix as well.
For us, our HR department works very closely with IT. It's a partnership. For us, one of the things that we've done with Epic coming on is we've actually asked for them too, as consultants, what do they think we will need? And so there is a master plan, if you will, of who we will be hiring. I can tell you who we're hiring, how many people this year, what the positions are. I can tell you what it will be in 2014. For each phase of this implementation, we know exactly who we plan on hiring and what those positions are. Because the organization is large and such a broad-based organization, we have numerous HR professionals, and IT, there's the IT umbrella, but then we have health information management, which is a little bit to the side, kind of reports up the same. HRIS is completely different, so they have another HR partner working with them. Clinical informatics is another area. So we have HR business partners that are well aware of their plans and what we need to be doing on our side, because as you know, you can't hire someone overnight. So we need to be planning ahead with our talent acquisition team and trying to get IT professionals and keep them engaged in case we don't have the role they want. When they're ready for one, that we can contact them when it becomes available so that we're ready to move forward.
In our organization, HR and the IT folks that are advising me, they do work very closely together. The critical piece is communicating to IT exactly the skill set that's required. They can virtually find anything you need, but you have to be very definitive in what that skill set might consist of, so they'll know what to go out into the marketplace and source for. We overlay that with the strategic plan so we can forecast as best we can from a expenditure standpoint what's going to be required and what's the headcount plan going to be for the upcoming year, so they'll go out and source what we need to give us the necessary resources, the human resources we need to fulfill that plan.
We work very closely with our Human Resources Department. I don't have any additional job openings I added late last year. The thing that I am working with the Human Resources Department with is last year I was given the responsibility of being over our transcription department, our medical records department, the people that still maintain our old paper charts, and our scanning department. And I thought it was really great that I got those people, because not only was I the guy that was trying to get rid of their jobs, but I was also able to try to find them other positions and to get them educated into doing the jobs that involve technology. One of my support specialist that I was talking about earlier is actually my former director of transcription, and she's an excellent fit. She knows how the doctors communicate. She knows how their notes look, and she is the designer, the architect of our structured notes, the ones with the discrete data in them. And she's also our trainer for the voice recognition system. All of our doctors have that available to them, and she's an excellent coach. And that's where I've worked with the Human Resources Department, is actually working on training and developing that staff to serve those future needs and to help elevate them into a longer lasting career than transcription.
Okay, thank you. Are there any questions out in the audience? Okay, right here, Dave. In the front, right here.
The vendors that you work with for your systems, like Epic and Meditech, and are they, or how have they helped or participated in workforce development, other than you buy the system and you're paying them to implement it? But are they offering anything else outside, like, you know, Epic certification, like Microsoft certification or something like that? Have you heard of anything like that, or have you implemented any additional kind of system certification programs in your institutions?
Allscripts is my EHR vendor, and they have an academy. We don't utilize it a whole lot. We use it for new personnel. Their academy does have a certification program, but the cost is very high. And I would consider a couple of my support people to be the most talented in the country. And we use them, and they love to be able to share what they know. It doesn't apply any certification to it, but I know that they've been offered jobs elsewhere in the country and things like that. They're very well known and all, but anyway, fortunately, I've been able to keep them and keep developing the staff with what we have.
Our platform is NextGen, and we deploy the NextGen practice management system, as well as electronic health record, as well as the dental product QSI, so they can all three talk together. And what I found, NextGen is very proud of their product and their training. I also have noticed an upsurge in ex-NextGen people forming their own companies and offering more intense services at half the cost. And with good follow-up, good support, they deliver what they promise at a very, very competitive rate.
I would echo what both of the other panelists said, and I can't tell you specifically what Epic has offered for us, but our employees had to take their test in order to continue to work in this environment, and so I'm sure that they're offering additional training and so forth. And as far as the resources, we just started, and that's the other reason this is very new for us, but their team has basically come into our organization, and we're finding space so that they can stay in our organization for a while. So they will be spending some quality time with our workforce.
Yeah. And for us with Meditech, certainly they provide the training for us as we would have need. And in terms of certification, I'm not entirely sure, but I would just add on to what Bob had mentioned, that you know, one of the risks is that we train up our folks and they become Meditech specialists and very desirable in the marketplace because everyone else is scrambling to get their EHR up. I would imagine it's true whatever the platform. And so we've lost a couple of folks to that. You know, the lure of the consulting world and dollars and using my recently gained Meditech experience can be very alluring. So that's a risk, and we did lose a few, but we've also, that just caused us to think more about some of our retention strategies. So what is the culture that we're creating, and how are we working with our folks to make sure that when they get the phone call to tickle their ears with another opportunity, that they say, you know what, but things are so good here. So, but anyway.
And that kind of leads to the next question is, what are you doing unique? Okay.
My name is Carrie Venmever, and I'm an IT professional, more than 15 years. Recently just took the certification for a healthcare implementation manager. My question is for you, Mr. Caro. I'm sorry if I pronounced your last name wrong. But I'm just curious about your outsourcing feelings. It sounds like it's been very successful for you. Kind of a two-part question. First part would be, do you feel like with all the rapid changes going on with the healthcare reform that you're being led more by the company that you're doing the outsourcing with as far as staying on top of the requirements that you need to be doing as a provider? Or do you, I mean, is it, I'm sure you have a partnership, but I mean, would you say if you had to put more emphasis on one or the other, would you say it would be more on the outsourcing company that you're using to rely on them for guidance, or do you feel like you're doing more of that? I have a second part to the question.
Okay. First part answer. I also retain a former chief information officer who has 18 years of experience, and when he stepped down from a major hospital in town, he formed his own company. And so I have him on monthly retainer. He's in my building probably, on average, 15 to 20 hours a week. I confer with him on strategy relative to what do we need relative to the network. I don't want to get the outsourced company involved in trying to help plot that strategy. I think there could be a potential conflict there. In fact, my base rule is that if you are the vendor of choice for my outsourcing, you can help me write the RFP, but if you do that, you can't bid. And so that's pretty much kept them on the straight and narrow as far as the acquisitions and the technology itself. I engage my managers, and I engage my consultant to help me strategize on where we need to go and what we can do. And I even include the CFO in those conversations because our resources are meager, and just to keep me grounded, because I'm kind of a techie, and I like the technology, but somebody's got to pay for it. Okay. The reason I chose the company, as I mentioned previously, I had only 2 IT people. I only have 2 on staff now, but what they do have are 45 engineers back at their company that if they run into a particular issue, whether it's SQL, Microsoft, Outlook, whatever, or Cisco, they have engineers that don't cost me anything, that they can tap into that expertise. So you get a lot more width and breadth to the expertise that you need when you do the outsourcing. At least that's been my experience so far.
Thank you. The second part is to the question is, and you know, I think there's a place for outsourcing. I certainly do, and it sounds like it's been successful for you. How would you feel if you were approached about taking some of those services offshore for your needs? What would be your first reaction to that?
Well, when I was preparing for the RFP for the outsourcing, I actually used some offshore on some issues that I was having, particularly with SQL databases. And that experience, after you get accustomed to the time zone changes, when you're getting calls at strange hours in the morning, aside from that, the work has been fairly satisfactory. And I certainly can't, I don't have any qualms with the pricing structure. They're eager, they want the business, and rates are very, very, very competitive. And as limited as my interactions were with them, the product, the results of the projects that I outsourced to them came back fine. And the end user had no idea that someone halfway around the world actually did that project for us. The concerns that one always has is the vulnerability and security of your network when you're letting someone else that far around the world to have access to gain entry into your system. It's no myth that most not-for-profit organizations are exploited. We take about 2,800 hits a day, people probing our network. And we're fortunate enough we have fairly good firewall protection, but many not-for-profits don't. And spammers get in those networks and they send millions of emails out overnight, unbeknownst to the not-for-profit entity. And so that security, I think Bob mentioned earlier, is always a concern, and you want to minimize that piece, especially now that we have the EHR. I'm really aware of tightening that down, even to the extent now that if our providers want a VPN into our network, they have to check out an encrypted laptop from me. I won't allow them to use their own computer systems anymore to VPN into the system, and we no longer allow thumb drives in the network, just because it adds another level of risk and heartache I really don't need to go through.
I may make a comment about the outsourcing question, offshore outsourcing. One of the reasons why these vendors have to do that right now is because there's not enough here. There's not enough people here to do that, and I think that the slide that was shown earlier, the big glut in the number of people to work these things. We have people from India in our system every day with our EHR system. Those people are health information technology specialists that are working in our system. It's simply because they've our vendors, no matter which one they are, have been trying to recruit college campuses and all that kind of stuff, and there just aren't enough people there. And it's very highly competitive unless you get specialized into health information technology, because those vendors are losing ground to Google and Microsoft and all of those others otherwise. So they have to go offshore to India, to Ukraine, whatever. And so we end up with those people working in our systems, and that wouldn't be my first preference.
So you see those people working offshore as with very specialized skills. You don't think, it's not something that with good searches and looking around with resources in the state or around that you could find them? Or is it through the vendor? You were saying, is it Allscripts that maybe some of their support?
Allscripts is one of them. They're not the only one. Even Microsoft outsources a lot of that. They're HL7 interface specialists. They're SQL Server specialists. They're, everything that we need, we're ending up with it's a lot more than it used to be. It's all these changes that every time, every 6 months there's some new thing that has to go into your system because the government is just moving so fast on these demands, and there is not enough programming or developer time available domestic. There's not enough of these implementation specialists available domestic, and so they've had to go offshore. They would much rather not deal with the time differences and the communication issues and things like that, and because it takes a lot of time to bring the people from India up to snuff with what they need done. And again, it's just as competitive for them. If the Google bus drives through their parking lot while they're walking into work, they may get recruited there, and the next day they're working for Google. I may have gotten off base there, but
It's okay. And probably also some cost are probably a big reason why to do some of it offshore too, I'm imagining.
possible.
Yeah, okay. Any questions from the audience? Okay, Todd, kind of where you left off, you kind of started the conversation on employee retention. So a little bit more on what you're doing to keep your health information technology employees and keep them engaged and want to stay and grow and learn as the ever-evolving environment changes.
Right. Some of the actions that we're taking are certainly just being aware of who our folks are, what's important to them, offering some flexibility in scheduling, certainly making available the training and education that we need them to have and that they're interested in, so they feel, I think it's typical for most IT folks, but not just them, but to remain current in their field, and so that's important for us. You know, one of the things that we're exploring now, and we probably should have been doing it long before now, but it's the concept of a stay interview. You know, so it's talking with them before they hand you their resignation letter, which is way too late. But before that, it's sitting down and talking with Mary and saying, "Hey, Mary, you know, you're one of my best people. You're key to the team. What really rings your bell? What keeps you coming back every day? And then what are things that don't work well for you here? Let's talk about that. And to the extent that we're able to do something about those areas of issue, let's see what we can do to fix that. So if Mary knows that I'm concerned about her and want to make the environment as best as I can, I think that's important. And it's not that we can fix everything, but I think just even having the conversation lets Mary know that I'm concerned about her, and that means a lot. And that's been borne out by when you read information about recruiting and retention. Those are some of the outcomes that come just from taking the action of even asking. So.
We also have the stay interview.
Okay.
We call it the voice of the employee, and go through different aspects. We do an introductory survey when they first come on to ask them about the recruitment experience. We do a survey for those at 5 to 10 years of service, and it goes on and on. And the other things we've done for retention, we have an employee engagement team. And that team has become a great resource for us at the hospital when we're implementing something new or we want feedback from employees. We go to that group to get their feedback. We also, as far as retention strategies, we have career ladders for our professionals, and the IT department specifically, they have a career ladder, and that helps people to stay engaged from the aspect of I can promote. Many of our people that are in the IT department promoted from within. The person who's our chief information officer promoted from within. Some of the others that are in senior level positions, so they know that's available to them. Probably at St. Luke's, one of our best retention factors is just our culture. A lot of people work there because of the culture, because they don't feel like a number when they're in our organization. On the nursing side, we have shared governance. So we try to make sure all disciplines are at the table at every level of the organization. Diversity, looking at that on your first, when you're at St. Luke's, that is one of the things every employee goes through. It's a half a day of diversity training, and that helps with retention as well, just ingraining them in our culture.
I think one of the challenges that I see daily is the difference in generations. Certainly, I don't anticipate hiring an employee tomorrow that's going to get a gold watch and be there that long, particularly in the more skilled positions inside the center. The employee typically says, "What's in it for me?" And they're skilled, they're hired guns, and once they have maximized what you can afford to pay as a not-for-profit, you say, okay, if I can get 2 to 3 years out of them, I'm good. 5 would be a luxury, but I don't anticipate keeping a highly skilled, and that also led to my desire to outsource the IT piece, is that they'll move on. Just because you train them, you increase their expertise, you're also increasing their marketability. And today they will leave after 2 years, 18 months to 2 years. Unfortunately, we don't have bonuses or dividend checks or stock options we can offer them, and that's pretty much what you're competing against, because you're competing against corporate America that has all of those perks that they can offer, and rightfully so.
I agree, Ralph. The slide in the presentation earlier had $32,000 on there for a health information technology person, and you know, my opinion is if you're going to pay the guy $32,000, you are probably going to lose him really quick. I don't have anybody that's making this. They're all making quite a bit more than that. I have people that are being paid anywhere from the mid-40s to about $80,000. It just depends on their skill level. And, you know, as far as retention goes, yeah, they're paid pretty well. One other thing that I do, I really try to announce their accomplishments to the owners of the organization, which are the 70 doctors that I was speaking of. We make a big deal out of milestones there for their accomplishments, and there are many to claim nowadays with all these things going through meaningful use and whatever. For instance, every one of our doctors qualified for stage 1. Every one of our doctors got the maximum amount last year. They received recognition, and they also got part of the pie for doing that work. Every one of our primary care doctors are NCQA certified for diabetes care. They get recognition for all the work that they did. None of that would have been possible if it weren't for electronic medical record system collecting the data and things like that. So we try to really publicize their accomplishments in our intranet website, making big news out of big things, and you know how much of a big deal they are to us. We still do the things with the interim interviews with human resources, trying to make sure that we're treating people right and that they're encouraged to voice their opinion, and I try to give them as much responsibility as they want and communicate with them as best I can. You're right, Ralph, they can go at any time, but I've had one leave me and come back 3 months later because he really liked it there and recognized that mistake, and I hope he continues to preach that gospel all along.
Okay, thank you. Are there any questions by the audience?
Do you see your budgets going up or down in the coming years? And if so, what would it be towards IT personnel or software and infrastructure spending as far as spending goes?
I see there's so many software requirements. Earlier I spoke about us having 23 different enterprise-type applications. And of my manufacturing background, when I was in manufacturing, you had one application, and it did the payroll, it did your inventory, it did everything that there was. And here we have all of these, the industry or the technology in the medical field is really pretty young. And so we had all these specialty things, radiology information system, which could also do its own billing and things like that. Well, none of them do a complete job is what I'm saying. And so you have to add an oncology chemotherapy tracking system. You have to add this or that. Now we have to add encryption for hard drives and encrypted software and all those. And to kind of reiterate what Ralph was talking about, we all get the doctor discount, which means twice as much as what everybody else has to pay. And anyway, the budget's requirements for the hardware is going up, requirements, virtual technology. You know, there's just a lot of things going on. I don't see an end to it as far as software or hardware goes. And we're just being pushed that way. Regarding my own personal circumstances with personnel, I don't necessarily see my personnel budget going up, but it's everything else that would be involved in an operating budget. It's bandwidth. The more we get connected to other organizations, we too are doing electronic radiology. We read for 2 different hospitals. We have to pay for all that bandwidth, and it's $1,000 a month here and $2,000 a month there. It's very, very expensive. I don't see an end to it.
My answer would be very brief: yes, yes, yes. Budgets will definitely go up with signing with Epic. That's obviously a huge cost. And everything that Bob said, you know, we're doing those things. And then I think for us, the cost of our personnel, that will go up as well, because we will have to add people due to that implementation.
I think once I figure out how to handle the ICD-10, we'll stabilize on personnel. The unforeseen, though, are the changes to the system that we have to do to keep compliant with the federal regulations. The ACL7 interfaces are not cheap, and for the life of me, I can't understand why you can't use one for multiple applications, but for every new application, you have to have the interface. And so every time, NextGen as a vendor, everything is in a multiple of 15,000, 20, or 30. And so whenever they talk, I know I need money. And, you know, you go back to your board and say, well, did you put it in the budget? Well, I didn't know about this 60 days ago. This just came about, and to be compliant, we have to get it installed within 90. So everything is a last-minute rush, and yes, it's going up and up and up.
I would echo everything that's been said. It's true.
I have a follow-up question to that. So in your opinion, do you think that overall healthcare costs will go down due to health IT, or is it going to go up?
I don't know if we can pin it on IT alone. There's a lot of factors, but I think healthcare costs will go up. But certainly, everything we've talked about, to invest in IT, I mean, that's got to be paid somehow. And so I think it would be reflected. The part of the question is, we can charge what we think we need to recover. If it's what we're going to get reimbursed for is the other part of the question.
I think, Samuel Rodgers, our challenge is a little bit more unique. Our mission is not to turn anyone away for ability to pay. And while my cost may go up, I can't, for the clientele, the patients we service, I can't pass that cost along to them. So the cost of their health care will remain constant. I have to find more creative ways to offset that cost, be it through grants. Typically, I'm at a point now that staff is already asked to do so much more with less, and there's only so much human that can be done, that it then becomes a function of the grant writers and seeing if we can source additional dollars, because our patients, they just don't have it to pay. And we service approximately 21,000 patients a year for about 100,000 patient visits annually. So it's a lot of healthcare, a lot of dental, and a lot of behavioral health.
Okay, any other questions? I'm going to ask one, and it had to do with budget, but just kind of some numbers. I know some of you said you didn't foresee that your numbers are going to increase at all this year, but I'm just kind of curious, how many IT staff did you add as full-time personnel in 2012? What's projected in 2013? And then what type of, or how many contractors do you plan to bring in via, even if it's Epic or NextGen or Meditech, whoever, and then how many employees do you convert? So that's kind of 4 questions, just numbers. Just curiosity, so we kind of bring all that together. And then if you know the percentage of increase of your budget.
I don't plan on hiring any more people in 2013. In 2012, I added 3. But we have about 700 employees in our organization, and we are the 3rd largest operating budget in the organization, largely due to software maintenance and support and things like that. As I spoke earlier today, it's, as far as I'm concerned, your growth and adoption of your EMR system is directly, I believe, is directly relative to how much push you have behind it, because everybody needs help and all that kind of stuff. And that a high number of people will get you a higher level of adoption in the system. We are very eager for that, and so we're pushing toward that. We're probably a little higher over industry average right now just because of our goals. But anyway, again, we have in our operating system budget about $2.5 million annually. That's not counting our purchases of hardware or capital equipment. And the salaries are roughly in the $500,000 range.
Okay.
In our organization, and I think back to last year, we added a couple of FTE to our team. We're currently have an opening for a help desk specialist, and we anticipate probably 1 or 2 more this year. Specific to, we have certainly a hospital system, but also a clinic-based system that we need to support as well. So we anticipate probably an FTE there, and then we anticipate the potential of another just to our staff. But more and more, as I mentioned earlier, we do rely a lot on the super users that are out in the organization, and so we lean on them, and probably will lean on them a lot more going forward.
So I think earlier I said I can tell you how many people need to be hired now and in 2014. I can tell you that if I look at the spreadsheet. I do not know that off the top of my head. Like I said, we have 10,000 employees, and IT is a system function, and so there are IT professionals being hired to support at the system level. And then as well, I see someone here from St. Luke's Health System that I know. Troy, do you know how many people? I didn't mean to put you on the spot. We have IT professionals at every entity within the health system. And so I don't know what that number looks like, but the budget for IT, I know, has continued to increase, as I said, because of the implementations we've done, and because it is so broad across the health system. Alone at at St. Luke's Hospital alone, we probably hired at least 400 people last year. And as for the system, I'm not sure what that number is, but, break that down into, we've hired a pretty good number of IT people.
Since I outsource the IT, that piece is fairly stable. I can anticipate a 5% per year, per annum increase in that charge. Before the end of this calendar year, we will add another 5 people in support of the IT mission, primarily in the health information management arena. And that doesn't necessarily deal with the 6 people in health information management that I will probably need to upgrade to help me deal with the ICD-10 that's going to come about. And 2 of those really need to be experts and specialists, 2 out of that 6 that have good communication skills that can help hold the hands of our providers through this transitional period that's going to hit in October.
Okay, thank you. Any other questions from our audience? Okay, well, that concludes the session. So thank you, panelists. I'd like to, if everybody can give them a round of applause.
Well, that's the end of our panel discussions today. Deb, would you like to wrap up with a few things on JCC? No? We're good? Okay. Well, great. Ralph, Todd, and Doris, and Bob, thank you again for your time today. We appreciate it, especially for those who've traveled quite some distance. We appreciate that. Surveys. Did we happen to get surveys?
Yeah, there is surveys.
Okay. We have surveys probably on the table.
No, they should have picked them up.
They should have picked them up. If you don't, on the table out in the back. Your feedback is really important to us. It's your feedback that helps us put together the content of these programs. And again, if you're not currently a member of HIMSS, we certainly would love for you to join our chapter and help us to fund even more initiatives. We have our next initiative coming up in June, right?
Yes, June 12th.
June 12th? Okay. I think we're going to be talking about ACOs. Would you want to mention a little bit about that program in June?
Sure. June 12th, we plan on having an all-day event here in the same rooms. We're going to start off with trying to set the stage, if you will, for ACOs and HIEs and how that all comes together, the interoperability, bringing in some people that can really help us understand where we have to be for the future, as well as just what all that means. We're looking at trying to bring in 3 different, the HIEs. We always hear about HIE and we're always thinking about the state HIE. What we want to do is talk about, there's a payer HIE, there's a public HIE, and there's a private HIE. And what's that mean to all the individual organizations? So then with the second part of the day, we're wanting to bring that all in and say, okay, what's this mean to IT and how's that going to affect IT? And how do you have to plan for what's going to be hitting IT in the next, not just the next year, but kind of where's this going down the road? So we'd love to have you come out. It'll be on our website. We'll be sending out some information here soon in the next few weeks, and I'm letting you know more about that.
Great. Thank you, Linda. Again, we're a volunteer organization. We are supported by the members' fees, the $30 a month, or a year, not a month. $30 a year if you're a chapter member only. I believe it's $160 for a national membership at this time. But please go out to our website, see some of our past presentations if you haven't seen them before. We are becoming a little bit more in tune with current technologies. Today we streamed this event. We didn't advertise that we were streaming. We have a few folks who are testing it to make sure it's going to work, and we will probably be streaming for future events. We do record these events. We have links on our website for that. And in fact, I think I saw our last event, we're getting ready to post those out there again with links to the YouTube sites where you can see past presentations that we've done. The PowerPoint presentations for most presenters today will be out there. Unfortunately, Sprint has a few restrictions on being able to post their information. Big corporations, we have lawyers, they like to hang on to stuff. But anyways, Julie has offered, if you will contact her, her or one of her team members will follow up with you if there's any questions you had about what she presented today. Everybody be safe on their journey home, and thank you again for coming today.